মুখটা দেখেই যা। আমার না বেশি
আমার বাইরে নিচে
বেশি নিয়ে রাখতে যাচ্ছি
নিচে এটাকে উপরে বাড়ে, এটা পুরো একটা নিচে রয়েছে,
এটা নিচু একদম
নিচে
আমি দেখি
খাদ্যটা দেখতে বেশি ভালো লাগছে।
কি বাবা লিভারটা বলতে গেছি মোটা পাটা একটা বড় কথা হচ্ছে কি এটা আমার কলেজ কলেজ সেখানে কলেজ কলাম টেন মেসেজ করছি
আমি এখানে বসে কি করবো?
কল কর না না
শুরু হয়েছে
দুটো 15 বাজে আমি এটা তোকেও বলতে পারি
would have studied already the anterior surface, superior surface, and posterior surface, right? Right. What about the inferior surface? Also, you would have studied. What is it? So inferior surface will be in between which borders? Inferior border and inferior border. Come on. Anybody else is coming? Right? Anybody else is coming along with you?
Yes.
Two people. Okay, let them come.
দুজনেই আছে
না স্যার পারবে না মোটামুটি স্যার নতুন দিয়েছিল আমাদের একটু বেরো রেখে দিলাম কি সব দেখতে হচ্ছে হ্যাঁ জয়জিৎ প্রত্যেক সপ্তাহে বাড়ি আসে
Okay, shall we start? Yes. Right? Okay. It will be the posterior-inferior border, and inferior border is the inferior surface. This widest surface is the inferior surface, which is also termed as the visceral surface. Rest of all the surfaces are called parietal surface. Why it is so? Why it is so? Why it is so? See here. The inferior surface is related to the viscera of the abdomen, right? What is meant by parietes? Parietes means, come on. Parietes means the peripheral wall of the abdomen, whether it is anterior abdomen or lateral or posterior abdomen wall. That entire parietal area is nothing but the parietes. Okay. So this other than the inferior surface, rest of the things are not related to any viscera, but it is related to the parietal peritoneum, which is in front of the diaphragm. So indirectly it is saying that walls of the abdomen. Can you get over? So that's why other than the inferior surface, rest of the surfaces comes under parietal surfaces, and this surface, inferior surface, is termed as a visceral surface because they are coming in contact with the viscera of the abdomen, like stomach or duodenum or whatever it might be. Okay. So from where to where the inferior border extends all the way from this lower part or inferior layer of the coronary ligament, all the way it will start from here, it will go downwards, go over here, and then it will be reaching till this part over here. Get it out? So this entirely, everywhere, the borders are like semilunar in shape. Get it out? So this inferior surface is related to, okay fine. How this inferior surface, okay, we'll discuss that later. So what are the relations of this inferior surface? The inferior surface is directed downwards and towards the leftwards. Downwards, backwards and leftwards. It is not absolutely posterior. Okay, because we have seen in liver yesterday, the anterior surface is in this manner, but the posterior surface is oblique. Getting it out? So the inferior surface is directed downwards, backwards and leftwards over here. Getting it out? So this is the anterior aspect, and this is the posterior aspect of the liver. This is the anterior surface, and here is the posterior surface plus inferior surface over here. Getting it out? Right? So this is directed in this manner. Okay. So towards the left side, there are few structures over here. You know that very well. So what are the structures with which it is related? So you know that, no? See here, just below the caudate lobe, this is the quadrate lobe over here. Quadrate lobe. Okay, what is the spelling? Quadrate lobe over here. It is bounded above by means of porta hepatis, and of course the lower end and the process. Which process is caudate process on the caudate lobe over here. Below by the inferior border of the liver over here. Towards the left side by means of fissure ligamentum teres hepatis. Okay, and then towards the right side by means of fossa for the gallbladder. It's the fossa for the gallbladder where gallbladder lies. Getting it on it? So the boundaries are fossa for the gallbladder. Gallbladder is the content of the fossa. Getting it on it? Okay. So these are the boundaries of the quadrate lobe over here. Okay. Just below the caudate lobe is the quadrate lobe. Simply to say that. Okay. So just to erase this, I have several other things.
Sir, in the bounds of the wall.
Simple. This is the caudate lobe over here. Okay. Above that is the caudate lobe, or you can take it as lower end of the caudate lobe with the caudate process over here, and then followed with the porta hepatis over here. Okay. These two above upper boundaries and lower boundary will be inferior border. This is upper and behind because it is obliquely directed. Upper and behind will be the caudate lobe above and porta hepatis a little bit below. Okay. Below the lower boundary is the inferior border of the liver. And the left boundary is the ligamentum teres hepatis over here. And then towards the right side is the fossa for the gallbladder. Getting it out? So this is called the quadrate lobe. Okay. So towards the left side of the ligamentum teres hepatis, there is a small elevation of the liver that is called, what is it? Exactly, tuber omentale. Tuber omentale is a slight swelling sort of or projection sort of structure of the inferior surface of the liver towards the left side of the ligamentum teres hepatis. Okay, it will be lying close to the lesser curvature of the stomach. The function of this is nothing but it will be separating the pancreas from the liver. So pancreas will be separated from the liver because of this projection in this manner. Getting it on it? Because here will be the stomach, behind the stomach will be the pancreas. Getting it up, right? So if the stomach is lying over here, behind the stomach will be the pancreas. Okay. This pancreas and the liver is separated through the lesser omentum by means of this tuber omentale of the liver. Getting it out? Right. So if this is the tuber omentum is over here, the pancreas will be over here, that will be having tuber omentale over here. So this tuber omentale and this tuber omentale will be separated by means of lesser omentum over here. Getting it out? So both of these will be separating with each other. Getting it out? Right. So okay, that's the least important thing. And then mainly the impressions of the inferior surface over here. So what are the impressions? So you are supposed to imagine the things over here. First of all, we have seen here yesterday will be the stomach. Esophageal impression. Abdominal part of the esophagus will be in the posterior surface of the liver over here. But in the inferior surface there will be gastric impression. Getting it or not? We are in the posterior aspect, that's why the greater curvature is facing towards this side and lesser curvature is facing towards the right side. Okay, this is the right side and this is the left side. Okay, so if you see that this inferior surface towards the extreme left side, there will be an impression for the stomach, that is nothing but the gastric impression. Okay, if you see that over here, the fundus and the lesser curvature, that means the body of the stomach towards the lesser curvature are related over here, but not the greater curvature of the body and the pylorus over here. Get it out? So the rest of the stomach will be away from the liver. So only the things which are towards the lesser curvature will be in relation with the inferior surface of the liver. This is very much important. Okay. So that's why this tuber omentale is separated from the tuber omentum of the pancreas through the lesser omentum over here. Getting it out? And then, so this, and then followed by this, what is this? No, this lobe. Quadrate. So what are the relations of the quadrate lobe? So towards the left side of the quadrate lobe, only the gastric impression over here. Over the quadrate lobe, if you divide it into three halves over here, three halves over here. So the upper half will be having the border, the free border of the lesser momentum over here. Is it not? Because the lesser momentum will be arising from here, all the way it will go from here to here. Getting down? So this lesser momentum will be extending till the porta hepatis. So this forms the free margin of the lesser momentum over here. So if you draw the lesser momentum, it will be going all the way from here till here. It will go in this manner. Getting down? It will go in this manner. This is the entire lesser momentum that will be extending till the duodenum over here, first part of the duodenum over here. Okay. So this is the free margin or right free margin of the lesser momentum over here. Okay. So here lies the epiploid foramen. Could you understand? Here this free margin below this is the epiploid foramen. Getting it? So here lies the lesser sac, behind the stomach is the lesser sac, in front of the stomach is the greater sac over here. So through this epiploid foramen, the greater sac will be communicating with the lesser sac over here. Getting it? So here towards the lesser curvature or towards the upper border of the duodenum, the arteries and veins will be going over here through the porta hepatis. Is it not? Right? The common hepatic artery will be going over here and everything. Okay. So through this free margin of this lesser momentum, all the vessels will be entering into the liver through this porta hepatis. Could you understand? Right? Now we are seeing the impressions over the caudate lobe over here. So the upper third will be occupied by the free margin of the lesser momentum over here. In the middle half will be occupied by see here, this is the fundus, this is the body, and this is the pyloric part of the stomach. The pyloric part will be ending with the pyloric sphincter over here. Okay, that pyloric sphincter will be continuous into the first part of the duodenum. So you are supposed to understand over here is the part of the pyloric part of the stomach and part of the first part of the duodenum are the relations for the middle half of the caudate lobe over here. Getting it out? So the stomach will turn in this manner and then goes upwards over here, and this is the pyloric part of the stomach over here. The pylorus continues into the first part of the duodenum over here. So the end of the pylorus and beginning of the duodenum, first part of the duodenum, are the relations for the middle half of the middle third of the quadrate lobe over here. Get it out? So below the stomach, we have seen one more structure. What is that? In the cadaver we have seen already. Below the stomach. Pancreas. Just below the stomach. Transverse colon. Okay. So transverse colon will be going all the way from so for example, this is a flexion. Transverse colon will be going in this manner. Getting it out? Right? So this is the left colic flexure, this is the right colic flexure. Okay. So in case of when the stomach is empty over here, this will be reaching the lower third of the caudate lobe over here. Getting it out? So upper third will be occupied by the right free margin of the lesser momentum, and then below, middle third will be occupied by the pyloric part of the stomach and first part of the duodenum, and even below that the lower third will be occupied by the transverse colon over here, which is lying below the stomach. But if the stomach is full, this will be pushed downwards, so you can't get this impression over the lower third of the caudate lobe over here. Only when the stomach is empty, it will be coming in contact with the caudate lobe over here. Get it out? Right? So this is the impression over the caudate lobe over here. Okay? Right. And then this duodenal first part will be turning into the second part by means of superior duodenal flexion. Anywhere this turn occurs, that is called the flexion. Colic flexures over here, duodenal flexure over here. Getting it out? So this is a superior duodenal flexure which will be related to the inferior surface of the liver towards the right side of the gallbladder over here. Getting it over? So what are the parts of the gallbladder? This is the fundus and this is the body and this is the neck. Okay. So fundus will be below, body will be below, towards the right side of the neck of the gallbladder. This superior duodenal flexure will be giving impression of the over the inferior surface over here. Getting it over? Here these are the three impressions over here, and then now we are crossing over the gallbladder over here. Okay. And now towards the right side of the neck of the gallbladder, there will be superior duodenal flexure will be giving the impression over the inferior surface over here. Okay. And again, obviously just below this duodenum, this transverse colon will be going over here and will be giving an impression of the which colic flexure over here? Right colic flexure over here. So duodenum just below that, here the stomach and duodenum, below that is the transverse colon. Here the duodenum above and right colic flexure over here. Getting it or not? So just behind the colons and the stomach there will be kidneys. Is it or not? We have seen the stomach and the peritronum with the transverse colon. So these are lying in the anterior aspect and kidneys will be lying on the posterior aspect, right? So this impression, whatever you will be seeing over here, this entire area is occupied by the kidney. This entire area is occupied by the kidney, right kidney over here. Getting it or not? Right kidney over here. Okay. So by this you can understand the kidney is over here towards the right side, and in front of that will be the colic flexure and the superior duodenal flexure over here. Getting it all right? Right? So here will be occupied by the right kidney. So obviously above the kidney will be the suprarenal gland, right? Suprarenal gland over here. But you are supposed to understand the suprarenal gland's impression is present within the bare area of the liver, not in the inferior surface. Try to understand this problem, okay? So within the bare area of the liver, there will be suprarenal impression. Because the kidney is lying within the inferior surface over here. So that's why suprarenal impression is lying over the inferior medial angle of the bare area of the liver over here. Getting it or not? Right? So only one impression in case of bare area of the liver is nothing but the suprarenal impression. But all these are the impressions of the inferior surface of the liver over here. Got it or not? So let us just summarize. All the way from left to the right, there will be fundic and body, fundus and body of the towards the lesser curvature of the stomach, and then followed by here will be the tuber omental, then followed by the fissure for ligamentum teres hepatis, and then followed by the caudate lobe. Caudate lobe upper third will be occupied by right free margin of the lesser ligamentum, and then followed by middle third will be occupied by pylorus and duodenum. Okay, end of the pylorus and beginning of the duodenum, first part of the duodenum. Okay, even below that, in case of empty stomach, will be transverse colon, and further towards the right side will be the fossa for the gallbladder, which is occupied by the gallbladder. And over the gallbladder, this duodenum will go towards the right side of it, and superior duodenal flexure will be giving the impression over here. Getting it or not? And then further towards the right side will be this right colic flexure below and right kidney above. Okay, partly the upper end of the kidney. The rest of the kidney will be over here. Getting it or not? Only the upper end of the kidney or upper half of the kidney will be giving the impression over here. Above the right kidney, the suprarenal impression will be going into the bare area of the liver. Understood or not, everybody? Right? So these impressions is easy to understand. But thing is, you are supposed to understand the peritoneal reflections of it. Everybody understood the peritoneal reflections? Epitorial pouch and Morrison and everything? Understood? How it will reflect? How it will reflect? See, there are two notches over the inferior border of the liver. There are two notches, you are supposed to know this. So the liver is divided into two anatomical lobes by means of falciform ligament on the anterior aspect, on the posterior aspect by means of fissure for ligamentum venosum above and fissure for ligamentum teres epitis below. Okay. Whenever this is attached over here, it will be forming a notch over here that is called the interlobar notch. Okay, interlobar notch, where the falciform ligament will be attached below on the anterior aspect. Here we go. And then followed by, there is a notch wherever this gallbladder is present over here. That notch is called cystic notch. Absolutely, cystic. These you are supposed to know. Cystic notch. Okay, these are the two notches. One is interlobar notch and one is the cystic notch over here. Okay, right. These things are absolutely fine. So now you are supposed to understand how the peritoneum is reflecting over here. The peritoneal reflections are called the false ligaments. Getting it on? False ligament. Triangular ligament on either sides, coronal ligament, all those things are false ligaments. Okay. And embryological remnants are true ligament. It's not the comparison between the ligaments between bones and over here. It's the ligaments over the, nothing but the peritoneal folds over here. Okay. True peritoneal folds are the remnants. Embryological remnants, nothing but the ligamentum venosum. Ligamentum venosum over here and ligamentum teres epitis. These two are the true ligaments over here, and false ligaments are rest of the ligaments. The right and left triangular ligaments and the coronal ligaments. All these are the false ligaments over here. Okay. So let us see how the liver is enclosed by the peritoneum over here. First of all, so everybody understood how the falciform ligament and the layers are covering the liver or not? Tell me.
Yeah, so if you come like this from the outside, the patient like this from this side, then it will cover the cover.
See, let us see how the peritoneum is covering the liver and how these ligaments are formed over here now. Okay, very easy to understand. First of all, this is the falciform ligament just towards the right side of the xiphisternum, which is situated over here. Just towards the right side of the xiphisternum will be the attachment of the falciform ligament all the way from the diaphragm till the umbilicus over the anterior abdominal wall. Okay, all the way from the diaphragm till the umbilicus, there will be a fold of peritoneum which will be going in this manner. Okay, all the way from here to here. Okay, bilayer. So obviously this falciform ligament is attached over here and over here also. So this notch is called the interlobar notch over here. It is because it is dividing it into right and left lobes over here. Okay, right. So I will draw how the right and left layers are enclosing the liver. So for example, if you take the left layer over here, this is the left layer. This is the left layer over here, which is enclosing the liver over here in this manner. This entire anterior surface will be occupied by the left layer of the falciform ligament. Getting it over? On the right side, for example, if you take it with blue color, for example, this will take it with the blue color over here. Okay. This layer is the left layer over here. This is the blue color. So this will be occupying the entire anterior surface on the right side over here. Getting it out? Right? So these are the two layers of the falciform ligament. So this is the left layer which is occupying the anterior surface of the liver. Okay. And or left lobe of the liver, you can see that. And this blue color is the right layer of the falciform ligament over here. That is occupying the anterior surface of the liver over here. Okay. And then coming to the posterior surface. So here you are supposed to understand posterior surface, here will be the ligamentum venosum and ligamentum teres hepatis over here. Okay. So this is the dividing point for the two layers of the peritoneum over here. Could you understand? On the anterior aspect, these are the two layers. One is the left layer of the falciform ligament, and this is the right layer of the falciform ligament over here. Okay. Now we are going towards the posterior aspect. Okay. So the posterior aspect, apart from the bare area of the liver over here, apart from the bare area of the liver, this entire inferior surface, here will be the inferior surface. Remember, this is the inferior surface. This entire inferior surface is occupied by the same layer over here. Till this side. Okay. So this entire posterior surface, nothing but the inferior surface over here, and just below the bare area of the inferior surface, everything is occupied by this right layer over here. Try to understand this properly. So the same blue color will be going backwards just below the bare area of the liver. So below the bare area of the liver is the inferior surface. Okay. Here it is absent because it is a bare area of the liver. Okay. So this entire inferior surface of the right half or right lobe is occupied by this entire right layer of the falciform ligament over here. So this half is this half over here. Could you understand? Right. So now this part will be occupied by the left layer. So this part, because this is indicating the falciform ligament on the anterior aspect. So these two ligaments are indicating the falciform ligament on the anterior aspect. Okay. So this area, apart from the left triangle ligament, is occupied by the left layer of the falciform ligament. Could you understand? So how the liver is occupied? This is a liver. It is occupied on left side in this manner and on right side in this manner. Could you understand? Leaving the bare area over here, leaving the left triangle ligament over here. Getting it out? Okay. So this area will be free from the peritoneal attachment over here. Getting it out? So if you see that this inferior layer is going over here towards the inferior surface, but it is occupying over the quadrate lobe, but it also goes over the caudate lobe over here. Try to understand this properly. Here, this inferior surface is occupied by the right layer of the falciform ligament over here, and this will be occupying the entire area till this ligament over here. The inferior surface will be entirely occupied till this part by means of the right layer of the falciform ligament. But the same falciform ligament will be going after crossing the groove for the inferior vena cava, will be occupying this part. This is a blue color one, blue color. The same blue color which is present over here will be occupying this entire part and even overlapping over the gallbladder over here, and this entirely is occupied by the blue color. Okay. Okay, this blue color is occupying the entire right lobe over here, and of course till the ligamentum it will be occupying, and it will be overlapping over the gallbladder. That means it is sealing the gallbladder between the inferior surface of the liver and the right layer of the, what is this? Falciform ligament over here. So if you keep this as a gallbladder, so the falciform ligament right layer will be overlapping over the gallbladder. Okay. So that's why the fossa for the gallbladder is non-peritoneal. Getting it out? Fossa for the gallbladder is non-peritoneal because it is going over the gallbladder in this manner. Getting it out? And then it continues over here and lines the quadrate lobe till this part over here. Here it will be joining with the right layer over, sorry, left layer over here. Getting it out? Here it will be joining with the left layer. Okay. Okay. And the same blue color over here, which is the right layer of the falciform ligament, which will be going beyond or towards the left side of the inferior vena cava and will be occupying the entire caudate lobe over here. Getting it out? It will be going over here. So far we have seen right-sided layer and left-sided layer. And now it is going horizontally. It is going vertically above and below towards the right side and above and below towards the left side. But now it is going horizontally over here. Getting it out? So the same layer will be going horizontally and will be occupying the entire caudate lobe over here. Getting it out? So after going over here, from here it will be reflected downwards as the lesser omentum. Could you understand? Right. So this is a blue color, nothing but the right layer of the falciform ligament going horizontally over here Not only over here, it is going horizontally above the porta hepatis and occupying the caudate lobe over here. Okay, and whenever it is reaching the fissure for ligamentum venosum, the right what is that? Right lip of the fissure for ligamentum venosum, it will be reflected downwards as the posterior layer of the lesser omentum over here. Could you understand? Because this is the posterior aspect. If it is going over here, this is the posterior aspect. You know? From here it will be going as the posterior aspect over here. So till what part? See here, this is the upper part of the porta hepatis. From this right margin of the ligamentum venosum over here, it will be extending till the upper lip or upper part of the porta hepatis over here. Till that part, this entire right layer will be occupying over here. Getting it over? So what about the left layer? So left layer will be obviously occupying the left lobe over here. Left lobe over here. So here both of these will be joining over here. At this ligamentum teres hepatis, both these layers will be joining. Getting it over? Remember this properly. Both these layers will be joining below the porta hepatis. Okay. Now, so this left layer will be occupying the left margin of the, what is this, right? Ligamentum teres hepatis, and will be extending till the lower half of the porta hepatis over here. Getting it over? This is the upper half of the porta hepatis, and this is the lower part of the porta hepatis. Could you understand? This is the upper half of the porta hepatis over here, and this is the lower part of the porta hepatis. If you see properly, the porta hepatis is not lined by any of the layers over here. So the porta hepatis is free from the lining of the peritoneum over here. So what are the structures which are not lined by the peritoneum? If you see that, all the way from right side to left side, bare area of the liver over here, and then the left triangle ligament over here, and cardiac impression over here, and then followed by groove for the inferior vena cava, and then floor of the fissure for ligamentum venosum, and floor of the fissure for ligamentum teres hepatis. Why? See here. For example, if this is the ligamentum teres hepatis, fissure for ligamentum teres hepatis. The peritoneum will be going in this manner. For example, this is a fissure. The peritoneum will be going in this manner. It is not covering the floor over here, because there is a content over here that is nothing but ligamentum teres over here. The content is the ligamentum teres over here. So that will not allow the peritoneum to touch the floor of the ligamentum, so fissure for ligamentum teres hepatis. Could you understand or not? Right? This also contains a ligament that is nothing, ligamentum venosum. Ligamentum venosum, which is the remnant of ductus venosus. Okay. In case of embryological life, there are two veins over here. One is the ductus venosus above, and what is it? Left umbilical vein over here. Those will be turned into the folds over here, ligaments over here. So because of the presence of those ligaments over the floors over here, the floors will not be touched by these peritoneal layers over here. That's why this fissure and this fissure over here are non-peritoneal. The floors will be non-peritoneal. Could you understand? Could you understand it, right? So if the ligamentum teres is present over here within the fissure for the ligamentum teres hepatis, the peritoneum on the right side, it will be going over here. On the left side, it will be going over here. Both will be joining over here. But it will not touch the floor of the fissure for the ligamentum teres hepatis over here. Got it or not? Right? So these, and fossa for the gallbladder also is not lined by the peritoneum, because the peritoneum is going over the gallbladder over here. Getting it or not? Right. All these areas are non-peritoneal areas. Okay. Okay, fine. So now what is happening over here? So this will be reflected as the posterior layer. This is reflected as the posterior layer of the lesser omentum, and here this is reflected as the anterior layer of the lesser omentum. Is it alright? For example, these pinkish layers are called anterior layers. Now it is overlapping over. Could you able to see that? Now the blue colored structure is nothing but the posterior layer of the lesser omentum, and the pink colored layer is the anterior layer of the lesser omentum. Okay, let us see now. So here again, now we are focusing from above downwards in this manner. We are seeing the cross section. Okay. This is the anterior surface of the liver, and this is the posterior plus inferior surface of the liver, and this is the right lateral surface of the liver. Okay. So now this is the fissure for ligamentum venosum here, from where the anterior layer, nothing but the pink color layer, is reflecting as anterior layer of the lesser, and then the blue colored layer over here is reflecting as the posterior layer of the lesser. So this posterior belongs to right layer of the falciform ligament, but the pink color belongs to left layer of the falciform ligament over here. Okay. So now it is enclosing the heart, the stomach over here. For example, this is the stomach over here. Okay. It will be enclosing, the anterior layer will be enclosing the stomach, covering the anterosuperior surface of the stomach. This is the anterior aspect, this is the posterior aspect. Okay. Anterosuperior surface of the stomach is covered by this anterior layer, and the posterior, what is posterior? Posterior surface will be covered by this posterior layer of the lesser omentum over here. Okay. And now whenever it is reaching the spleen over here, kidneys over here, so this anterior layer,
So that will be the left kidney.
pink color, no?
So left kidney, that will be the left.
Sorry. So here try to understand this properly over here. So now we are focusing on the greater sac and lesser sac. Okay. See here properly. So this is the pink color layer over here, nothing but the anterior layer. This is the anterior layer which belongs to the left layer of the falciform ligament over here. Okay. This anterior layer is going over here and enclosing the anterosuperior surface of the stomach and enclosing the spleen in this manner. It will be going over here. This is the hilum of the spleen over here in the middle. It will be going in this manner and encloses the spleen. Only the anterior layer will be enclosing the spleen over here, and then goes towards the left kidney and reflects as the parietal peritoneum of the abdominal wall over here. Getting it? Or it will not be enclosed in the kidneys because kidneys are retroperitoneal structures. Okay. Right. So this is the fate of the anterior wall of the what is this? Lesser omentum. Okay. Now coming to the posterior wall. This bluish color which belongs to the right layer of the falciform ligament is reflecting down as the posterior layer of the lesser omentum. That will be enclosing the postero-inferior surface of the stomach over here and will be reflecting in front of the spleen. Okay, this is the in front of the spleen or towards the medial aspect of the spleen in this manner and goes in front of the left kidney and crosses further. Here will be the aorta and vena cava over here and goes even in front of the right kidney and will be joining with the same layer where the choric lobe is present over here. So this layer will be going over here and turns at the level of the spleen and goes in front of the kidneys and then join with the same layer over the right end of the choric lobe. Getting it out? It is like a sac in this manner. Getting it out? So here it will start at the level of the right lip of the ligamentum venosum over here, fissure for ligamentum venosum, and ends at the right end or right margin of the choric lobe over here. Getting it out? So it will start over here. And for example, this is the lesser sac and it will end over here in this manner. So the lesser sac is touching the choric lobe over here. Getting it out? So rest of all the areas belongs to greater sac. Only this part belongs to the lesser sac. Rest of the areas belongs to the greater sac. So the same, for example, the same blue color over here belongs to the greater sac, but the same blue color over here belongs to lesser sac. Could you understand? Right. So it is starting all the way over here and starts over here. Just behind the stomach is the lesser sac over here. and it will goes back and in front of the kidneys and joins at the right part of the caudate lobe over here, or right margin of the caudate lobe over here, like a bag. So it will be going in this manner and encloses the caudate lobe in this manner. Okay. So only this part is the lesser sac. Rest of the areas above or below or in front is belongs to the greater sac over here. So now you are supposed to understand, for example, this layer of the falciform ligament belongs to which sac? Greater sac. This part belongs to greater sac again. This part greater sac again, obviously. Okay. So only this part is belonging to lesser sac. So the same layers, but the sacs are different over here. This is the greater sac layer and this is the lesser sac layer over here. Getting it out? So to say the posterior layer of the lesser omentum belongs to which sac? Posterior layer of the lesser omentum belongs to which sac? Lesser sac, absolutely. Or posterior layer of the omentum which is enclosing the stomach belongs to which sac? Lesser sac again. Getting it out? So in this manner the questions will be asked. Got it out, everybody? Right? So this is the right and left layers of the falciform ligament which is enclosing the liver. But there are few absent areas over the liver over here. Those are called bare area and non-peritoneal areas. Okay, from where the ligaments will be formed over here. So, did you understand the boundaries of the epiploic foramen or not? Boundaries. Okay. Everybody understood the boundaries of the epiploic foramen or not? Understood or not, right? Boundaries of the epiploic foramen? Understood, huh? Tell me. What are the boundaries of the epiploic foramen? It should be a short notes. Inferior vena over where? Posterior. Okay, and then in front will be? Okay, first one you have to say that the free margin of the lesser omentum which contains all this hepatic artery level. And then superior liver means caudate lobe and caudate process of the caudate lobe. Inferior liver means transverse mesocolon. Seriously? No. Epiploic foramen lying at what level? Exactly, first part of the leader. That is the flow. Absolutely. Could you imagine or not, right? Okay. So, see here the boundaries of the epiploic foramen over here. Okay. See this is the lesser omentum over here. Now we are focusing from abdominals. This is the cross section. Again the anterior surface and posterior surface which is oblique over here. Okay. This is the inferior vena cava and this is the lesser omentum over here. This is the bare area of the liver. Okay. And this is the left lobe of the liver over here. Okay. So in front will be the free margin of the lesser omentum and behind will be the inferior vena cava. Could you able to see that? This is in front and this is behind. Okay. Here will be the what is it? What is this? Epiploic foramen. Here will be the epiploic foramen just below the porta hepatis. Getting it up? Okay. So here in front will be the lesser omentum. Behind is the inferior vena cava. Above here it is situated nothing but the caudate lobe over here. Is it not? In between the inferior vena cava and this fissure for ligamentum venosus, there is a caudate lobe over here. Right? So imagine the caudate lobe over here. Here will be the intestines passing over here, nothing but the duodenum. So above it is bounded by the caudate lobe over here. below by means of the first part of the duodenum, that means roof and floor, and in front will be the free margin of the lesser omentum over here. Behind is the inferior vena cava. Did you understand, right? You understand about it, right? So if the lesser omentum is coming over here, inferior vena cava is situated over here, right? So above is the caudate lobe, here is the quadrate lobe. Could you imagine, right? So lesser omentum is coming over here. This is the inferior vena cava over here. So in front is the lesser omentum, behind is the inferior vena cava over here. Here is the caudate lobe, right? Here is the caudate lobe, here is the free margin over here. So below the porta hepatis is the epiploic foramen over here. Okay. So above is the caudate lobe and the processes over here. Okay. And below will be the duodenum. This lesser omentum is attached to the floor, nothing but the duodenum over here, which is forming the floor over here. Could you even imagine or not? Could you even understand or not? Right? It's a short note. Okay, you are supposed to understand. Okay. So let us see first of all the first ligament. False ligament is nothing but coronary ligament. Coronary ligament. Okay. The folds of the peritoneum are called ligaments. Getting it on? So among them, true and false ligaments. False ligaments are called the rest of the ligaments, and true ligaments are the embryological ligaments. Okay. Right. So this is the coronary ligament over here. Coronary ligament will be having. So now we are at the bare area of the liver. Getting it on? Bare area of the liver. So it will be having two layers over here. One is the superior layer or upper layer of the coronary ligament, and one is the lower layer of the coronary ligament. So what is happening over here? These layers will not be ending over the surface of the liver. These will be going above and will be attached to the peritoneum of the diaphragm. Could you understand? So for example, if this is the liver over here, this is the bare area. This is the bare area over here. Okay, and this is the superior layer of the coronary ligament. This is the inferior layer of the coronary ligament. These layers will not be stopped over here. These will be extending till the diaphragm and will be enclosing the bare area of the liver. It will be enclosed in this manner. Could you understand? So this is, that means the bare area is connected to the diaphragm through this coronary ligament in this manner. Could you understand? If the coronary ligament extends further right side, it is called the right triangular ligament. That means the margins, whenever they are joining with each other, that is called the right triangular ligament. Again, this entire part will be attached to the diaphragm over here. So this part will be attached to the upper aspect of the diaphragm. This part will be attached to the right side of the diaphragm. So it will be holding the liver. For example, this is the right side and upper part. It will be holding the liver in this manner. Getting it on? So this part is attached to the upper part of the diaphragm. This is the superior layer and this is the inferior layer of the coronary ligament. Both will be attached to the upper part of the diaphragm over here, or through the peritoneum. Parietal peritoneum it will attach. Okay. And this, whenever these two are joining over here, this will form the triangular ligament, right triangular ligament. Again, that will be attached to the right side of the diaphragm over here, hanging the liver all the way from the diaphragm in this manner. Got it on everybody? Right? So this upper layer of the coronary ligament and lower layer of the coronary ligament belongs to which sac? Greater sac, obviously. Apart from the caudate lobe, everything belongs to greater sac. Okay. So this is the right triangular ligament, and left triangular ligament will be, left triangular ligament, how it is formed? Whenever the liver is occupied by which layer of the falciform ligament? Left layer of the falciform. If this is the left layer of the falciform ligament, it should be enclosing the entire left lobe and leaving a gap over the superior surface or towards the posterior superior border over here. So that gap is nothing but the left triangular ligament. Again, that will be attached to the diaphragm above. So coronary ligament is attached above, right, left triangular ligament is attached above, but right triangular ligament is attached towards the right side of the diaphragm. Okay, but this left triangular ligament will be having a free margin over here. Is it not? This is attached nothing but like a free margin will be there over here, just like the falciform ligament's free margin. Where is the free margin of the falciform ligament over here? See here, this falciform ligament is attached to the anterior wall, anterior abdominal wall in front, behind to the liver over here. Is it not? This falciform ligament is attached above to the diaphragm and below to the anterior abdominal wall. This layer. This layer is attached to the diaphragm and to the anterior abdominal wall over here. Get it up? And if you see that this is a deeper layer. Okay. For example, if you take this is the falciform ligament over here. This is the falciform ligament over here. This part will be attached to the liver and this part will be attached to the anterior abdominal wall. Okay. So this is the attached margin of the falciform ligament over here, and this is the free margin of the falciform ligament over here. Getting it on it? So this is the free margin of the falciform ligament. But this part is attached to the anterior abdominal wall again, till the umbilicus. Could you understand? right? So this is attached to the diaphragm and then followed with the anterior abdominal wall till the umbilicus. Getting it out? But this part, whatever it is attached to the liver, is the attached part of the falciform ligament. And again, this part, which is not attached to any structure over here, that is nothing but the free margin of the falciform ligament. Getting it out? Free margin of the falciform ligament. This will be containing which structures, right? Ligamentum teres. The same ligamentum teres will be continuous above within the fissure for ligamentum teres hepatis. Could you understand? So the content of this free margin is nothing but the ligamentum teres hepatis, which is nothing but the remnant of left umbilical vein. So this part is nothing but the left umbilical vein over here. That will be continuous over here as the ligamentum teres hepatis on the posterior aspect. Could you understand or not? Right? Could you understand or not? Right. So what are the other contents of this falciform, free margin of the falciform ligament? Any idea? Para-umbilical vein. Okay, the contents of the falciform ligament are important. One is the obliterated left umbilical vein, nothing but the ligamentum teres over here. Another one is the para-umbilical, because this is the umbilicus, para-umbilical vein, parallel to the umbilicus over here. Getting it out? Try to understand this problem. And this will be forming this. You are supposed to understand what is this accessory portal system of Sappe. What is this accessory portal system of Sappe? Any idea? Any idea? This accessory portal system of Sappe, actually portal means what? What is portal vein means what actually? What is happening in the portal vein? Starts with capillaries and ends with capillaries. That is called the portal vein. Getting it on? For example, you take the normal portal vein, it is connecting the splenic vein, superior mesenteric vein and forming a portal vein and then divides into right and left portal branches, portal vein branches over here. Okay, so it is beginning with the capillaries, here it is veins only, but it is ending with the veins over here. So these two veins, pairs of veins are connected by means of a portal vein over here. Then what is porta hepatis? What is porta hepatis? Porta hepatis means it is an entry point to the liver, portal. Through this portal, you have to apply for the examination. So that is the porta hepatis, entry point for the liver. That is porta hepatis. But portal vein means it is connecting two different veins at both the ends of it. Getting it on? That is the true difference between portal vein and porta hepatis. Getting it on? But the porta hepatis is not a true gateway for the liver. Why? Why it is not a true gateway? Even it is termed as a gateway, it is not true gateway. Why? What is it? What is
hepatic veins?
Hepatic veins will not be draining or will not be passing through the porta hepatis over here, but straight away it will be entering into the inferior vena cava, supporting the liver over here. Getting it alright? So this will be asked in the why. What is it? Why porta hepatis is not a true gateway? Because hepatic veins will not be passing through the porta hepatis, but they will be directly entering into the inferior vena cava through the posterior surface over here. Got it or not? Okay? Obviously, by piercing the groove for the inferior vena cava. Absolutely. Okay. Right. So this is the para-umbilical vein which will be connected with the veins of the diaphragm over here. Could you understand? This para-umbilical vein will be connected with the veins of the diaphragm over here. But what happens to this para-umbilical vein? It will be ultimately delivering the things into the portal vein again. Getting it or not? So that's why it is called the portal system of Sappe. That means here the para-umbilical vein is acting as a portal vein over here, connecting the veins of the abdomen or the diaphragm over here with that of the portal vein which is situated within the porta hepatis. Get it up? So this is the para-umbilical vein connecting the veins of the abdomen and the diaphragm over here. You can take inferior phrenic veins, you can take that. Or here there will be inferior epigastric veins over here. Getting it out? All these veins over here are connected. These are the systemic veins which are getting connected to the portal vein over here. Getting it out? So there are two branches of the portal vein over here. What are those? Right and left. To the right lobe and towards the left lobe. So this is towards the left side, right? So obviously towards the left division of the portal vein will be connected by means of this para-umbilical vein over here. Okay, connecting the systemic with the portal vein over here. That's why this veins is connected by these veins by means of this vein. That's why it is called the accessory extra portal system of Sapé over here. Got it already? Okay. So the abdominal veins are connected to the portal vein through this para-umbilical vein. That's why this entire system is called accessory portal system of Sapé. Got it already? Right? Right. So these are the contents of the falciform ligament. Which margin? Free margin of the falciform ligament over here. Getting it already? Right? So all these structures are present towards the free margin of the falciform ligament over here. Getting it already? Attached margin will be attached to the liver and it will be diverged and occupying the entire liver. So this is the difference between attached margin and free margin of the falciform ligament. Getting it or not, everybody? Right? Understood or not? It's a vast topic, but you are supposed to understand. Okay? So groove for inferior vena cava is peritoneal or non-peritoneal? Non-peritoneal. Very good. Okay. So one more thing. So you are supposed to understand a few things over here. So whenever so this is what is this ligament called? See here. Here one more thing you are supposed to understand. So this is attaching with the diaphragm, is it not? This is attaching with the diaphragm. Okay. And one more thing you are supposed to understand over here is, for example, here there is a kidney over here. For example, there is a right kidney over here. Right kidney, sorry, not right kidney. Okay. So the same layer over here is also reflected backwards, okay, towards the upper end of the kidney over here. For example, this is the inferior layer of the coronary ligament. Is it or not? Inferior layer. This layer, this is the superior layer, and this is the inferior layer of the coronary ligament. So these will be attached to the diaphragm over here. Getting it? So the same layer over here will be turning backwards and running in front of the kidney and continues with the paracolic gutter. Could you imagine or not? Difficult, no? It's okay. For example, okay. See here, now we are focusing on the hepatorenal pouch of Morrison. Okay, what is it? Hepatorenal pouch of Morrison. Okay, see here. This is the superior layer of the coronary ligament and this is the inferior layer of the coronary ligament. Could you imagine? And here on that side, towards that side, now we are focusing on the sagittal section. Okay, on that side will be the triangular ligament, right? Triangular ligament over here. Okay. This is a superior layer which will be attached to the diaphragm above. This will also be attached to the diaphragm above. Okay. But here, this inferior layer also gives rise to one more layer that will be going behind and will be going in front of the kidney over here and goes downwards towards the paracolic gutter. What is paracolic gutter? Whenever the large intestine over here is occupied by means of the parietal peritoneum, that entire area is termed as paracolic gutter. Parallel to the colon, there is a gutter. Getting it out? So whenever the large intestine is situated over here, for example, the large intestine is situated over here. So this large intestine is also a retroperitoneal structure. Kidneys are also retroperitoneal structures over here. Okay. So this will be covered by the parietal peritoneum. Is it all? So also it will be covering the kidneys over here. So here the same layer, the inferior layer of the coronary ligament, which is present over here, will be reflected backwards towards the kidney and continues with the paracolic gutter over here. Getting it out? So this is the inferior layer, this is the bare area of the liver, this is the inferior layer of the coronary ligament. It will be reflected towards the kidney and goes downwards and continues with the paracolic gutter over here. Getting it out? So what is the significance of this over here? For example, there is an injury to the urinary bladder over here. the urine will be leaked into the peritoneal cavity. This urine can reach this hepatorenal pouch whenever the patient lies supine. This urine which is leaked into the peritoneal cavity can reach through this parabolic gutter into the hepatorenal pouch of Morrison and infecting these organs over here. Getting it out? Right? So, in a reverse manner, for example, so if there is any gallbladder cholecystectomy something, so there will be continuous discharge of bile over here because there is no gallbladder to store. Getting it out? So, in the absence of the gallbladder, the bile will be, sometimes it will be leaking over here. So, that leakage will be lodging into the hepatorenal pouch, and further if the patient stands up, it will be reaching all the way towards the pelvic floor over here. Could you understand? So, the blood, if there is any leakage of the blood because of the operation or anything, whatever it might be, fluid or infective pus or blood, whatever it might be, if it is getting leaked all the way from the gallbladder's surgery over here, that will be drained all the way through the parabolic gutter and will be reaching the pelvic cavity over here. Getting it out? From here it will reach over here, or from here it will reach downwards over here. Getting it out, right? And one more thing, because the lesser sac is extending till this part over here, here is a hepatorenal pouch of Morrison over here. So this hepatorenal pouch of Morrison communicates through the epiploic foramen to the lesser sac over here. Could you understand or not? Could you understand or not? No, not? Sir. No, no, sir.
সরে গেল ছোট
ও ভালো আর রাখতে পারছি হ্যাঁ এক ঘন্টা 4 মিনিট 9 মিনিট হয়েছিল
9 মিনিটের বেশি হবে
See here everybody, now we are at the posterior aspect of the liver over here. So here will be the hepatorenal pouch of Morrison. Imagine that this is a bare area of the liver over here. So this lower layer will be turning backwards and will be occupying the or lying in front of the kidney over here, forming the hepatorenal pouch of Morrison. Okay. So this hepatorenal pouch of Morrison, so this is the lesser sac over here. Could you understand? This is the lesser sac. Okay, it should be a bit above. Okay. So, but here there is a epiploic foramen below it. Is it or not? Right? Could you understand or not? Or in another sense, okay, I'll show it in the viscera directly. Okay, knew about this part, but you are supposed to understand there is a communication between the hepatorenal pouch of Morrison and this pelvic floor over here. Getting it out? Okay, this you understand? I'll show the things in the viscera, how the lesser sac is communicating over here. Okay, so what will happen if just remember the hepatorenal pouch and the lesser sac are communicating with each other through the epiploic foramen. So if there is any perforation of the stomach on the posterior aspect, here will be the stomach. In front of the lesser sac is the stomach over here. Is it not? If there is any perforation occurs, the infection will be formed within the lesser sac. So the same infection will be carried towards the hepatorenal pouch of Morrison also. Getting it down right? So horizontally it will be communicated. Vertically also it will be communicated in this manner. The infections will be communicated in this manner. Getting it out, right? So I will show it in the results. Okay. So what is the blood supply of the liver? Right? This is important. This is also important. Blood supply of the liver by means of hepatic artery and portal vein. So portal vein and hepatic artery will be carrying the blood to the liver. Okay. Why portal vein is important over here? Nutrients. So whatever the digested material which is absorbed from the duodenum will be carried through lacteal. You know the lacteal?
Yes, sir.
Right? The lymphatic channel within villus. Each and every villus there will be a lacteal. That's the lymphatic channel. That will be carrying everything towards the portal vein. So the portal vein will be carrying the nutrients to the liver. For example, glycogen, it will be carried from all the way from here to liver, and that will metabolize and release the glucose into the blood. In the same manner, all what are the vitamins, minerals and everything, that will be carried through the portal vein into the liver and it will be metabolized later. But hepatic artery will be carrying oxygenated blood, normal oxygenated blood. So this is for the oxygen purpose and this is for the nutrition purpose of it. Okay. So 75% of the blood will be by means of portal vein within the liver. If you divide it into 75% and 45%, 75% of the liver, 75% of the blood will be carried by portal vein, and only 25% of the liver will be having by means of hepatic artery over here. Getting it or not? Both the bloods will be mixed within the liver in the sinusoids and will be delivered into the which vein? Central vein, and central vein will be finally delivers into hepatic vein, and hepatic vein delivers into iris. Okay. So this is the thing which is also asked. Okay. So let us see the inferior surface.